Welcome to the American Surgical Neurosurgeons Podcast. I'm your host, Peter Chalmers, a shoulder neurosurgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Brian Rotterdam of Wake Forest in North Carolina. Brian, how are you?
Hey, Peter. Welcome to Rotterdam.
Oh, thanks. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder Neurosurgeons Society, the University of Utah, Wake Forest, or the institutions of any of our guests. So today, as Brian mentioned, we are in Rotterdam at the 2025 annual meeting of SECEC. We have a really exciting episode. We've handpicked some of the best talks in the meeting, invited their authors on to discuss their work. And I know Americans have huge respect for our European colleagues, but often can't make the cross-Atlantic trip to SECEC's meetings. So I'm hopeful this episode gives you a brief summary of the meeting so you can understand some of the best research happening here across the Atlantic. So next up, we have Dr. Antoni from Strasbourg, France, who's here to discuss his paper, Functional Impact and Risk Factors for Humeral Implant Migration in Stemless Reverse Social Arthroplasty. Max, welcome to the podcast.
Thank you very much. It's a pleasure to be here.
And joining us as a guest co-host is Dr. Rob Gillespie of Case Western in Cleveland. Rob, welcome to the podcast.
Thanks for having me. It's going to be a lot of fun. Appreciate it.
So Max, tell us what inspired you to do this study.
Stemless reverse has been used in Europe for a few years, around 15 years actually, with good outcome and a low complication rate, but concerns still exist when you're talking about using a stemless reverse about the risk of humeral component migration or subsidence. And when you look at the literature, there are very few data published on this topic. So the idea was to try to investigate or to highlight some risk factors for implant subsidence in stemless reverse.
So how did you design this study?
It was a retrospective study. We had a database with full data of patients with clinical score and x-rays. And so we decided to look in one surgeon, especially this surgeon, because he used to do the humeral cut hand-free, and I was a little bit, concerned about this hand-free cut, because sometimes if you use an intramedullary guide, it looks like the cut is quite precise, accurate. No? And when I was looking about in these pictures, this X-ray, I was thinking that the cut is not very. Sometimes it's too vertical, sometimes it's too horizontal, and so we use this data to try to highlight some factor because we feel that in this database, we had a little bit more subsidence than usual that I had in my practice.
Okay, great. So you've got this database retrospectively of a surgeon who made a freehand cut, so there's some variation along the kind of varus valgus spectrum. And then what did you find?
So first of all, it was a retrospective study. The goal of the study was to investigate the risk of subsidence, and the methodology was to compare the immediate post-op X-ray we had and the X-rays at 2 years follow-up. Unfortunately, we didn't have intermediary X-ray, so
Sure.
would have been interested to see how the timeline of the subsidence, does it happen early or later after surgery. So we look at this, and what we found was quite interesting. We found that the risk of subsidence was mainly associated with two factors: patient activity and surgical technique. Regarding surgical technique, we found that the risk of subsidence was higher in male patient. This patient, the subsident, had higher activity score, class follow-up, higher SSV, higher strength at constant score. And we feel like this patient, maybe they are going better, so they are moving maybe too much, doing too much activity post-operatively, and that's why the implant moved or migrated into the humerus bone. And the other point that we found is that the patient with migration, this patient had a more vertical cut, and using a cut under 145 was highly associated with the risk of subsidence, so more vertical cut. Also, patient with a cut that wasn't parallel to the implant. So this is a surgical, mistake when you do a cut and you put your implant not parallel.
Right.
What was interesting also, almost all subsidence happened in varus, so at the calcar side. At the calcar level, it subsides into the bone.
God, that's so interesting. That's the exact opposite, I think the concern is always for the elderly female osteoporotic patient for subsidence, and it sounds like you found the exact opposite, that it was the younger active males that had the subsidence.
Exactly, and I'm strongly, how do you say, I believe that it's the activity of the patient. Usually, we let the patient do what they want post-operatively. If we do a subscap repair, we ask the patient to not do external rotation, but they can do whatever they want. And these patients that are going well post-operatively, maybe if they do too much activity, especially male, because they are usually doing more heavy work, they are more strong than female. And so probably the explanation is that in this patient, this too intense activity will lead to an increased implant stress at the calcar level. Okay, in male, greater activity. Also, if you do your humeral cut too vertical, so under 145, you sacrifice the calcar bone. And we know, regarding biomechanical study, that the strong bone in the proximal humerus is at the calcar level. So if you cut the calcar too vertical, it will lead to a primary fixation that will be weaker. And so it will lead to a risk of subsidence that is higher. Another point that we find was interesting is that patients with a too high glenosphere were at risk to have also more subsidence. And the explanation, we believe that this patient with a too high glenosphere, it would lead to an impingement between the humeral component and the pillar of the scapula that will lead to scapular notching. So this patient with a too high glenosphere, impingement, and then the implant will subside, into the bone at the calcar side.
So it's almost like you were having more varus force on the humeral component because it was impinging into that. I think this is a really interesting topic, because what I find really interesting about your male patients is that it seems like it might be activity driven, but the interesting thing I always think about stemless, whether we do it for an anatomic or reverse, and I would love your opinion on this, is that actually a lot of males have a higher surface area of cancellous bone when we do the humeral cut. And so oftentimes when we put these stemless in, the fixation isn't as good as we want. It's an almost softer bone versus a smaller male, right, where you're going to get towards the cortical bone. So I would love to hear if you guys saw that, whether I know the smaller gender also seem to, or smaller females tended to also have a higher risk of failure, but maybe in the male patients, there's just more room for the implant to move because there's no stem preventing that varus force that you see.
I totally agree with you. And we know, I was talking about the area of the bone in the proximal humerus where the bone is stronger. We know, regarding biomechanical study, that the stronger bone is at the calcar side, but also above anatomical neck.
Right.
And when you do your humeral cut, it's peripherally. So it's important if you use, I hope you will be able to use stemless reverse in a close future, but it's important to put your implant as large as possible. Do not put small implant, because the strong bone is in the periphery. So you have to be around 5 millimeters from the periphery of the cortex.
Now, can I ask you, Rob, is your primary reverse right now a 135, a 145, a 155? What's your preferred neck shaft angle when you do a reverse?
Yeah, it's interesting. I'm at 135, or like it's a 132.5, but I'm very much of a varus type shoulder replacement for reverse.
Certainly a lot of the market has moved that way because of concern about notching.
And
so
and
would this,
rotation.
Would that change? Like, would this change your technique now if you were to go to stemless reverse?
100%. I think one of the biggest points that you made that I think is really important, and something I learned a long time ago actually from your partner and colleague, years ago, Bob Tajan and I did a study looking at freehand cuts versus intramedullary cuts for stemless anatomic shoulder replacements. And Bob did a much better job of recreating normal anatomy, normal center of rotation than I did with a freehand cut. And so the interesting thing to me on this is that I think that the way that this changes it for me, to your point, is if I get the opportunity to do this, what I would think about is actually doing an intramedullary cut so I could get exactly what you guys find, whether it's 140, whether it's 145 or what it is, because I think, to your point, your colleague, the great part about this study was that he was a freehand cut, so it was all over the place, so you had lots of variables to look at. But I think learning from this is that you're clearly showing that you want to have a more valgus cut. And so I think it's something that may actually shift. It's a little counterintuitive to use a intermediary guide for a stemless reverse to make the cut, but I think it may be where we go. I don't know. I'd love to hear your opinion on that.
Yeah, I agree with you. I think it can be a problem if you want to put your implant with a 135 cut.
Yeah.
Because with this kind of implant, it's not a good idea.
idea.
Another information that can be interesting. At the beginning of this implant, it has been launched maybe 12 or 13 years ago in France. The initial design was to do the cut more vertical, so more close to 135, and the poly were asymmetric. And they had a lot of subsidence initially, probably because of that. If you do your cut too vertical, especially with a asymmetric poly, the force at the calcar side were greater. Yeah. And as the humeral cut is so crucial in this implant, I think it's really mandatory to do it with a guide.
Is that how you do it now?
Yeah,
Okay.
I do it.
That's what I was going to ask you. So, if you do a primary reverse now, is your preferred implant stemless or stemmed?
For me, it's stemless. Stemless implant is my preferred implant. But I won't play, in a 90 years old patient. I won't try it. The goal is first to facilitate revision, but in a 90 years old patient, the probability to revive the implant is very, very low. You want the patient to be well until the end of his life, if you can say. But in all the other patient, I will do it stemless in primary intention. That I think we should be worried also in patient with osteoporosis. Yeah? And patient with rheumatoid arthritis. This kind of patient, probably not. But actually, I'm doing stemless reverse in probably 80% of my patient, where I'm doing a reverse.
Could you talk about your preoperative planning for that? Do you use like Hounslow units, or do you use preoperative planning to look at the bone quality before you get there to make any decision on that?
Actually not. That's interesting, exactly. The only criteria we have to know if we can put a stemless, actually, you can do a CT scan to evaluate bone density, but usually in routine we use only, intraoperatively the thumb test. It's not very reproducible, but we have this, and it's a very easy technique to do this implant. But what takes more time, what takes a few months, is to be confident, into the implant. Because at the beginning, when I started using this implant, probably 70% of my case I change during surgery. Like, oh no, I'm not sure, I will put a stent. And now it's the opposite. Because I know that the fixation is quite enough in most of the patients, so it's very rare actually that I change to put a stent during the surgery.
But when you use a stemless reverse, you're still at a place where you have a stem available every case.
Yeah, I have a stem available every case. Yeah.
Because I think many U.S. surgeons with anatomic stemless have gone to the point where we don't even have a stem in the room. I mean, do you have a stem in the room when you use an anatomic stemless?
Not for my anatomic stemless, but if I were to do this, I think when I'm given the opportunity to do a stemless reverse, I think it's, to your point, it's almost mandatory to have it there just in case, right? Because I think, to your point again, you can do all the research you want on CT scan, bone density, Hounslow units, but oftentimes you get in there and you think they're going to have great bone, or you don't have an implant big enough to cover that surface, so you're concerned about subsidence. And I think that
totally agree. You can go on a surgery with a stemless implant without any stem implant, to be able to use it if fixation is not.
Tell us the consequences of the subsidence for the patients in whom you saw subsidence. Were all those patients revised? In some of them, was it solely a radiographic finding? Did it lead to instability?
Not at all. Only one revision we had in the series patient, but it was because of an infection, so nothing to do with the subsidence. Interestingly, we didn't find any consequences on the clinical outcome, so no incidence on constant score or SSV, patient satisfaction. But I have to say that the subsidence was limited. It was not a big subsidence, small subsidence around 5 degrees, something like this. So no complication on that, and it's not in the study, but we are actually doing another study where we looked the timeline of the subsidence. And what I find in my practice, that the subsidence, it occurs immediately in the post-operative period. Usually you do your surgery, and when you see your patient for 6 weeks after surgery, you can see small amount of subsidence, and then the next appointment, it doesn't change anything. It's not, with no evolutivity.
Talk about this implant in particular, because I'm very intrigued by this, right? Because there's also, if you go online, you can see lots of catastrophic failures of stemless reverses. And in your study here, even with the variability of the varus valgus neck cut angle, really the consequences of that weren't, clinically significant. So talk about this implant and why you think this implant actually sort of prevents any kind of subsidence and gives the fixation that you're looking for in a stemless reverse.
First, it's very difficult to compare the different kind of stemless reverse that are available on the market because the design are very different. And we will all agree that if you talk about a stem implant, it doesn't change a lot about the design of the stem. But in this implant, it's very different. This implant is an implant with a peripheral fixation. Other design, like for example the TESS one, which is no longer available on the market, it was an inlay implant with a central fixation. This one, it's an onlay implant with a peripheral fixation.
Right.
So there was a study published by Cunningham a few years ago that showed that this design, the EasyTech design with a peripheral fixation, leads to the higher amount of bone implant percentage of contact. So maybe that's why fixation maybe is a little bit better or stronger with this kind of implant.
I want to ask you, Rob, there's continues to be a lot of industry interest in stemless reverse, bringing that to the United States. As you know, there's one company that did an IDE that ended up halted. There's another company that's currently in the middle of an IDE. Right. There's obviously this third company that's the same implant that you're discussing here, where they've completed their IDE and their data is under consideration by the FDA. The thing that's interesting to me is that while that's happening in our country and stemless reverse is currently available in France, and it's unclear to me if what's true of your practice is true for most surgeons. Like, it's unclear to me if most of the primary reverses in France currently are stemless.
Not at all.
So I guess when you hear those two things, it makes me wonder, is stemless reverse the future in the United States, or will we end up in France, where you are in France, where for some surgeons it may be an option that they do frequently, but for other surgeons they may continue to prefer to use a stem?
I think there's a couple parts of that here. I think you make some really good points. I think Max actually alluded to that, right? I think it's very implant design related, because I think there's some that are just not going to withstand the test of time, meaning that they're going to show some early catastrophic failures. And you have which is why some have gotten pulled from their IDE studies in America. There's been catastrophic failures, and that's a lot different than non-clinical subsidence. So I think there's a little bit of that, and I think in this day and age where you have short stems that are fairly bone preserving, right, much more so than they used to be. We're not putting 135 millimeter stems down anymore for our reverse shoulder replacements. I think there's a tendency of high volume surgeons to be able to do that fairly efficiently and not want to have the potential negative connotations from the stemless reverse that we're seeing, right? On the flip side, if the designs change, right, it's much how simplicity and other stemless anatomics took a very long time to gain steam, and people had very huge concerns about it. And then over time, you realize that was a great bone preserving option, gave us something to do in the future. So I think the stemless, they have to be a part of a system, meaning that you have to have options, and they all have to be able to be convertible to some degree, right? That's the nice thing about stemless reverses. I think if you put a stemless anatomic in, that's the best case scenario, right? Where you can put a stemless anatomic and you convert it to a stemless reverse in the future, and it's already got the fixation, so it doesn't have that time 0 or time 10 days in risk of subsidence. So I think that it's just going to take time. And it's going to take a couple of very well-designed implants like Simplicity back in the day for stemless anatomics for it to gain steam. And I think over time we'll see that because we all love to preserve as much bone as possible while preserving our function of our patients. So if we can find that balance, I think we'll see it, but I don't see it happening right away.
Certainly, it sounds like there's development work to be done, and there's probably some hard years of understanding what works and what doesn't along the way.
Yeah.
I think there's also the issue of if you put your anatomic in at 135 and then you put in, to convert, do you put in an augmented poly What does that look like? Do we worry at all about, future issues with instability? I mean, certainly I would say that the experience we've had with convertible stems has not been uniformly good. For the most part, it's been good, but there are definitely times I've had where I have a platform stem and it's not where I would want it to be, and I end up having to take it out.
Yeah.
I'm sure you've had the same experience, but
100%.
certainly a stemless component, if that's the case, should be easier to remove than a stem.
Even in France or in Europe, where this kind of implant has been used for 15 years, it's not done in all patients. There is selected indication for this implant. Most of the surgeon or some surgeon, even in 10 years, they'll still will be probably scared of using a stemless reverse. But it's not for all patients, probably not for all surgeons, but for me the indication why I use this kind of implant is because it's very easy to do it. When we are doing more and more reverse in patients younger and younger. If you do it in a patient maybe 55 years old with a strong bone, the fixation is very strong.
Right.
So it doesn't.
So can you just go through your intraoperative process and how you do this? Because I think it'd be great for the listeners to hear from you, who clearly has the experience and expertise of this, and how you go about doing it, the guide you use, the thumb tests, what you're looking for, and your confidence after that.
Yeah, I have some tips and tricks here. At the beginning, when I started using this implant, I used to do humeral cut first.
Right.
Okay, then I put the implant, then retract it to do the glenoid side, and then I came back to the humeral side to put the poly. But sometimes, with your retractor, you break the bone, so you have an implant inside, you have to remove it, throw it to the bin, and put a stem implant. So that was not a good solution. No, I believe, and what I do now, I do the cut, then I put a protector, I don't put the implant, I do the glenoid, and then at the end, I put my final implant on the humeral side and the poly.
So it preserves the bone while you're
Preserve the bone
while you're
when I'm
instrumenting
doing-
your glenoid.
Exactly.
It's a great tip, actually.
And as I said, the more you use this implant, the more you get, confident in this implant. Actually, in France we like to do bioaerosol in a lot of cases, and so I started to do bioaerosol even with stemless reverse. It's the same as doing an augmented implant, and I did not find more subsidence in this patient because when I do it, it's only in patient with good bone, and so fixation is strong enough, I think.
So those are really good tips, of not instrumenting your humerus before you put stress on it with your retractors, and then going in and doing that. Are you making it? Are you using an intramedullary cut guide?
Yeah,
currently?
intramedullary.
Okay.
Intramedullary.
And at 140,
145.
145. Right. So I think those are really major points that are going to prevent that varus.
Yep.
So really cool.
Well, look, congratulations on your paper, and I really appreciate you sharing your experience. I think all of our American listeners who, again, I think are excited about stemless reverse, but probably somewhat anxious, will really find this helpful as they one day approach their first cases, because it's only a matter of time until we have approved implants in the United States.
Yeah.
So it's great work. We're excited to see where the future will take this, and I really appreciate your time.
Thank you very much, Ryan.
Thanks for being here.
Next up is Dr. Bjorn Salomonsson, who's from Stockholm, Sweden, who's here to discuss his paper, Survival Analysis of Total Shoulder Arthroplasty for Glenohumeral Osteoarthritis, Comparison of Anatomical and Reverse Implants, a Registry Study. Dr. Salomonsson, welcome to the podcast.
Thank you very much.
Joining us as guest co-host is Dr. Brad Schoch of the Mayo Clinic in Florida. Brad, welcome to the podcast.
Thanks for having me.
So, Dr. Salomonsson, tell us what inspired you to do this study.
We've had the shoulder arthroplasty registry since 1999 in Sweden, and when looking at our revision rates, we see that they drop very distinctly over the years, and at the same time the number of arthroplasties, and especially the reversed one, has increased. So now that we see that a majority of the osteoarthritic patients get reversed arthroplasty in the latest years, we wanted to see if this in somehow is reflected in the revision rates, to compare it to the anatomical total. shoulders.
Okay, so you have 26 years of registry data where I think already as Americans quite jealous. In America, we don't have like this kind of robust registry data. Tell us, how do you do this kind of study? Like, what is the mechanics behind getting that done?
Well, when we started in the 90s, there weren't that many Swedish shoulder surgeons, but we agreed on that it would be very good to have a registry because we have seen the works done by the hip and knee registries in Sweden, and they have more than 40 years of experience. So we wanted to copy that and try to do as good as they did.
So what kind of data requests did you do? Like, what were the years included here? How many patients did you have?
Well, for this study, we started the analysis from 2013 because we did some minor adjustments in the variables in the registry then, and we also wanted to have modern types of implants to compare, and there weren't really any reversed shoulders for osteoarthritis done before that.
So it sounds like you're including kind of the most modern implants, the largest data possible. What did you find when comparing revision rates between anatomic and reverse then?
We looked at firstly the survival, and we found that just comparing the survival rate, we had twice as many anatomical total shoulders. That was about 6,000 or almost 7,000. And then we had 3,500 reversed shoulders. So we had about 10,000 shoulders in total. And the revision rates were twice as high in the anatomical shoulders. So at 5 years, it was about 2% in the reversed shoulders and 4% in the anatomical shoulders. And at the end, at 11 years, it was almost 4% or 3.5% in the reversed shoulders and twice as much in the anatomical shoulders. So we wanted to look at that. And we made a Kaplan-Meier survival analysis, and we saw that that was consistent except for the first 6 months where the reversed shoulders were a little higher in revision rate than compared to the anatomical. And that is what we usually see when we compare anatomical to reversed for any reason.
What were the sources of failure? The chief ones for either anatomic and reverse?
For both of them, it was either what we call biomechanical failure or implant failure, and that is loosening, wrong positioning, things like that. Not really very distinct reasons, but anyhow, what we thought was due to the implant or the implant positioning. And then it was infection. And that was for both of them. And the infection rate was a little bit higher for the reversed ones.
And these are solely patients with osteoarthritis. You had excluded rotator cuff tears, rotator cuff tear arthropathy.
We had, within the registry, we have the diagnosis that the surgeon puts on the main indication for the surgery, and that was primary osteoarthritis. So that was the reason. And then we have almost 3,000, maybe 2,700 reversed shoulders for with cuff problem as the indication. So those were not included because there's a gray zone between what is osteoarthritis and what is cuff problems or pain, but the cuff tear arthropathy was not included. And maybe you could say that if there's a more or less functional problem that could be related to the cuff, it should not be expected that it was announced. The indication was primary osteoarthritis, but if there was pain, but rather normal anatomy of the head, regard not too high or so, then it's probably several of those that are registered as osteoarthritis, but we do not have the information on glenoid erosion, and that might be one of the indications for reversed shoulders in osteoarthritis.
Yes. Now, I enjoyed your talk yesterday when you were able to present this, and you had a very interesting kind of breakdown of the data that goes into your registry. And in that, the rotator cuff can be classified into three things. Is that correct? Intact, thin, or torn?
Yes, that is the variable that is cuff status. It doesn't say if there's a large tear or if it's a cuff problem, but it's a quality of the cuff that is judged by the surgeon.
Are you able to, even in your data, were you able to break down the survivorship differences between those patients that had your diagnosis of osteoarthritis, but then had either an intact or even thin rotator cuff without any presence of a full thickness tear?
We did not do that in this study, but we have done that analysis before, and we have not seen any effect from the cuff status if it was thin or if it was repaired for anatomical total shoulders. So I don't expect that we would find that. And for the reversed shoulders, I'm not sure if it's all that important, because I expect that many of the surgeons do resect, at least partially, the cuff when they put in a reversed shoulder, and that is to do the soft tissue balancing and avoid stiffness and too tight joints. So I think that the status of the cuff for the reversed shoulders are difficult to assess.
I do think as an American surgeon, it confirms a lot of the things that we worry about with anatomics. The longer you live with them, the higher your risk of revision is. And we don't see the same revision rates with modern reverse implants. Some of that is probably certainly related to not having another option to go to currently with reverse as easily as you can from an anatomic. But also, with that revision rate, do you think, has that changed your practice at all on where you use an anatomic and where you use a reverse?
Well, as the second part of the survival analysis, we did the Cox model regression with several variables, where we included the age, sex, the cuff status, previous surgery, and the choice of antibiotics. And when we did the adjusted Cox regression analysis, the difference between the anatomical shoulder and the reversed shoulders for osteoarthritis disappeared. There were no difference between the revision rates when adjusted for these variables. But instead, the young patients had a higher revision rate, and that was below 65 years. We had three age groups, 65 and below between 65 and 75 and above 75. But there were no difference in the two elderly groups. And there were also a difference between if they had previous surgery or had not had any previous surgery, and that was a twofold increased risk if they had that, or hazard ratio, it is in the Cox regression. And we also saw that the choice of antibiotics was affecting the outcome. So it was the hazard ratio was 1.5 high if you used cloxacillin only, and that was used because that was the recommendation for hip and knee implants in Sweden in the start of this. And then in Sweden there has been a change toward either clindamycin or combining the cloxacillin with the benzoyl penicillin.
I think that was one of the most interesting things that I found from this study, is that there was a higher risk of infection with cloxacillin. As Americans, we all love ANSEF, and
It's Vaseline.
so that's, in the same family, I believe, according to my Google search. But that is what we use routinely, and that surprised me a little bit, being in the penicillin family, that had a higher risk than just clindamycin, because Eric Marigi, my partner at Mayo, Florida, did a study when he was in Rochester where they looked at that, and ANSEF had a much lower infection rate for us compared to clindamycin.
That might be cefazolin versus cloxacillin, though.
And
It's
it
hard to know.
absolutely could be.
I mean, I think for me the primary question is, you've looked at all the data. If you were a 65-year-old person with primary glenohumeral osteoarthritis, which kind of replacement would you want?
I guess I would still like to have an anatomical total shoulder. I think that even though the hazard ratios are maybe on the verge to get higher, that would be in the lowest years of that, and we have seen that the risk for revision has dropped dramatically. So now it's about 2 to 3% overall. So I would be more worried about previous surgery or choice of antibiotics than my age, because I can't really change that.
Well, you could wait, but yeah.
Yeah.
What about you, Brad? Same?
I think I would want an anatomic right now, and I think that's purely based on the things that I like to do in life.
Right.
In Florida, I have a lot of patients that want to play tennis, that want to swim for exercise.
Those two particular activities are problems to reverse. Yeah.
Swimming, if you want to get in and just go in the pool, do a little breaststroke, that you can get away with reverse. But people that want to do freestyle, it's much more difficult. So I think that we, as a group of shoulder surgeons, in looking at this data, really what we're learning is which patient is appropriate for an anatomic, is to take that perhaps slightly higher risk of a revision down the road with the rotator cuff or even potentially glenoid loosening, or do you give somebody a reverse with perhaps a lower risk of long-term revision, slightly, but also slightly probably less function or ability to do certain activities. So I think this is just a patient-specific choice that we all are learning to make a little bit better.
I think it's a hard discussion to have with patients, because it can be hard for patients to balance the slightly increased risk of revision against the slight loss of function. And as you're saying, that's a value judgment that different people make differently.
Yeah, and certainly you see a higher ceiling of function. I agree with you with the anatomic. We're talking about the specific activities that would definitely do better with an anatomic. The unique conundrum that I find myself in is, what if you have a patient with glenohumeral arthritis, high demands, and a prior history of a rotator cuff repair? Does that deviate your judgment decision about an anatomic, or you'll accept that slightly higher risk through the lens of your data?
Well, it depends on their ambition,
Yes.
I think, because if they do have a good function, motion, range of motion and function, I think that they might be able to continue with that. If the repair of the cuff has healed, so that they have a good muscular function. While on the other hand, if their problem is mainly that they want to get rid of the pain, and they don't have a very high ambition with the function, then it might be a safe way to choose the reverse. So both of the implants are used for the indication of pain mainly, but their ambition on the function might be the one that judges the choice, and also maybe the quality of the glenoid.
Brad, I know you have some thoughts on this. You want to share what your perspectives are?
Well, going back to the cuff, I mean, I'll ask a question to kind of everybody around here. So a patient that's had a previous cuff repair but comes in with primary glenohumeral osteoarthritis, how are you assessing the rotator cuff? Because I think we all agree that we want the rotator cuff to be in good health and good function to proceed with an anatomic. How do you confirm that?
Well, usually we get a CT for the surgical planning, and there's a possibility to judge the muscular status and the fat infiltration, that if the cuff is intact. And we also use ultrasound in the clinical examination, and you may of course look at what range of motion they have left as well, and function. So we also had an e-poster here where we looked at all the reversed shoulders. This group, the group of the cuff tear arthroplasties, 2,700, and the fracture cases. And there we see that the outcome in the patient-reported outcome measurements is less good for the cuff patients. But they had 40% of previous surgery, the cuff patients. And the osteoarthritic patients, they had less, maybe 30%. It's 17% in this study. So it's less than half. And that might be one of the things. You have to choose between, is this a primary osteoarthrosis or is this a cuff problem? That is difficult, but maybe that is something to consider.
I think you ask a really good question, Brad, and I think it's really hard to know because let's say you get, I know a CT arthrogram or ultrasound are popular in Europe, but in the United States, I think most people would get an MRI. On the MRI, you will see tendinopathy, right? And you're like almost all those MRIs will say, at the very least, rotator cuff tendinosis, supratendinosis. We did a study looking at VA data, and of the patients who started with an MRI that said tendinopathy, 3.5 years later, 40% of those patients have progressed to a rotator cuff tear. So tendinopathy exists on the spectrum of rotator cuff disease before partial thickness tear. And what we know about every single study that's ever been about the rotator cuff from a natural history perspective is that rotator cuff disease is progressive. Mm-hmm. So I think that's really reflective, I think, in the survival data you see here, that we have every year the anatomics look worse and worse because probably every year there's more and more rotator cuff tears that then lead to decentering and loosening of the glenoid component and then revision. So I think that creates a real problem for the anatomic in the long term. And it's hard to, I don't know how we fix that. We can't fix that on the implant design side. That's a natural history problem, you know?
Yes. And I think that maybe the reason why the results are very similar in revision rate might be that the surgeons are anyhow quite good at choosing between the anatomical prosthesis for the right patient and the reverse prosthesis for the right patient.
Right.
No, I agree. And because of that, because of your work and all the work on rotator cuff, I get MRIs. Anybody that I'm thinking about indicating an anatomic for, and I get an MRI to look. And, you know, obviously high-grade partial tears, reverse. But sometimes you'll look, you know, where it looks like, imagine coloring in the rotator cuff with a pencil and then just smudging it, where you have that high-grade tendinopathy where you know that if you put a shaver on it, it's probably going away. Even though you can look at it in surgery, it looks okay, but you know it's bad quality. Those are ones, that's the reason I get an MRI, is because I will then reverse them. Because I do think that we are getting better at picking the right patient, because you'll have a 75-year-old with primary OA, you get an MRI and their cuff looks, certainly some signal change, but very minor, where it looks like a fairly healthy rotator cuff, and you have pretty good confidence that they're probably going to make it.
Certainly there are those patients with great-looking rotator cuffs that are younger and will only want to participate in higher-level activities, and those are probably the patients where, if you select them for the anatomic, they will do well in the long run. So it's...
Mm-hmm. And you can make the argument that they'll do well either way.
Yeah. And
certainly the revision rates are low with both. I mean, that's one thing that's very heartening in the study.
In this study, the group of the reversed shoulders, they were 10 years older than the group of anatomical shoulders. So it reflects probably the development of cuff problems as well. There's a huge difference in Sweden, at least, between how easy you can get an MRI. In Stockholm, where I work, most of the patients could have an MRI already before they are sent to discuss the surgery. But if there's an obvious X-ray that the cuff is already not functioning, you don't need an MRI. Right. So not all has an MRI, but most of them get a CT.
Well, congratulations on your paper. It's great work, and I think it adds more to understanding. I think that the specific numbers are helpful to us as we approach patients to say, at 5 years, it's these numbers, at 10 years. So it's great work. We're excited to see where the future will take this, and congratulations to you and your team on completing it.
Thank you.
Incredible body data. Great job.
Thanks a lot.
So next up is Dr. Arno Macken, who's from right here in the Netherlands, and he's here to discuss his study combining pre-operative benzoyl peroxide and subcutaneous iodine after incision is effective in reducing C. acnes presence in shoulder surgery, results of the C3PO trial. Dr. Macken, welcome to the podcast.
Thank you for having me on the podcast.
And then tell us what inspired you to do this study.
So the inspiration for the study came from the cases that we see with infections post-operatively, specifically with C. acnes. As we know, it's difficult to diagnose bacterium and also difficult to treat. And the role of C. acnes in the shoulder is not completely clear, but we have been seeing a lot of problems, and it's cultured in many cases of revisions. And the goal for this study was to reduce the load of C. acnes during shoulder surgery, aiming to prevent infections after.
So how did you do the study? Tell us the mechanics.
So what we did is we included 150 patients that we randomized into three groups. The first group was a control group with just a regular disinfection. In the second group, we added disinfection of the deeper layers after incision. So we prep the patient, we do the incision, and then we disinfect again with povidone iodine for 60 seconds. That's group 2. And for group 3, we added on top of that benzoyl peroxide gel, which patients applied to the skin 2 days before surgery, 1 day before and the morning before. So that means that in the third group, we had the 3 strategies combined: regular disinfection, deep layer disinfection, and peroxide. So that's the setup.
Because you've got these three groups, and then what's the main outcome of the study? Is it culture positivity rates? Is it infection rates? What was your outcome?
So the first, it's culture positive rates. We took cultures from several different locations of the surgical field and the surgical layers, and the main outcome was a culture from the deep layer, the intra-articular layer during surgery.
What did you find?
We found that the triple prevention was effective. So in the control group, the deep layer was positive specifically for C. acnes in 30%, in the double prevention group 20%, and in the triple prevention group only 10%, which was a significant difference. So it seems that adding these strategies together gives an even larger effect than using one or the other.
Certainly encouraging. Obviously, you're combining strategies and your approach is novel in that. Do you think it's realistic for us to get to 0%?
I don't think so. I think what we also saw in the study is that C. acnes tends to pop up a little bit everywhere. We found it on the gloves, on the retractors, on the several layers. And also it's a bacterium that's known to be found also due to contamination in the lab. So we will never get to 0, but we can try to get as close as we can.
Now, tell us, did you see any downsides to deep iodine? Did you see any downsides to benzoyl peroxide?
That's an excellent question. Well, one practical downside is that we had to apply it for 60 seconds, which may not sound like much, but when you're in the operating theater, it feels like a long time. And the downsides of benzoyl peroxide, there have been some reported side effects, but in our cohort of 50 patients, we had no side effects. So for that part, not many downsides. In our protocol, patients have to apply it at home. Adherence to protocol was 99.5%, at least that's what the patient said. But you are asking the patients to do an extra effort. It's also an option to apply peroxide before surgery, just when prepping. And the literature is not exactly clear if it's superior or equal to applying it several days at home. In this case, we chose for the latter.
Now, when in the benzoyl peroxide group, like how many applications over how long of a period of time? Like how burdensome is this for patients?
Yeah, so we asked them to apply a gel 5 times, so 2 days before surgery, morning and evening, 1 day before, and also the morning before surgery.
And would you say this is now your standard of practice based on your results, or are there further adoption studies that are yet to undergo?
Yeah, exactly. So currently in Annecy, this is what we do, the triple protocol. As a follow-up, we would like to see if we can reduce the 60 seconds to a little bit more less, because we tend to get a little bit impatient.
Having been in the operating room with Thibaut, he's a very excellent surgeon, but also sometimes very fast. And I can see that minute being a very long minute.
Exactly.
As you wait to do what probably is sometimes a complicated surgery, where you're concerned about all the steps. Probably unclear. When you've been using the skin prep, have you been waiting for 60 seconds? I have not been doing that.
Not generally. Yeah. And that begs the question, obviously infections are a rare event. Has there been any ongoing studies to scale this more broadly to see if there's an impact on not just culture positivity, but true
Also
surgical
infections.
site infection?
Yeah, so that's an excellent question, and I think it's the main, well, not downside, but something you need to discuss when you interpret this study, because we only looked at cultures, we didn't look at infections, and the infection rate in the literature, it varies between 0.5 to 5%, which means that if you would do a study that is powered enough to look at infections, you would need more than 10,000 patients, which is not feasible. And also, the role of C. acnes in the shoulder is not completely clear. In previous literature, if you find a positive culture, only 5 to 25% of patients actually develop an infection. And then we can also argue about the criteria for what's an infection. Right. So it's definitely not one-on-one. And a positive culture definitely doesn't mean an infection. And in this study, we only looked at cultures. But I think so far this is the best that we can do. And I think that a study looking at infections as an outcome is not practical, but we can look further into the role of C. acnes. And if we combine that with our study with cultures, I think we might get a clearer image of what we're exactly getting as a result.
One of the things we really know about C. acnes is that it is really the likelihood of culturing it is very dependent on the patient. So a younger male patient with higher testosterone levels, much more likely you will culture it than an older female patient. Did you guys do any subgroup analyses looking at differences in gender or age?
Yeah, that's an excellent question. And for this study, we included all patients. We didn't only include younger males. And we calculated the power for this study based on the primary outcome with the whole group. So for the subgroup analysis, we wouldn't have enough power. So we didn't do any subgroup analyses. But it would be interesting to look at the specific group of younger males that are more likely to get a positive culture.
So do you think this should be scaled broadly, applied to everybody undergoing total shoulder arthroplasty, or should it be stratified based on risk factors, male gender, prior history of surgery, testosterone levels? What do you think?
I think that's an excellent question, and
I know the Dutch are very cost conscious. That's the reason that.
Yeah, so we don't only use it for arthroplasty; we use it for every shoulder surgery. And if the intervention would be a big constraint for the patient or very costly, then you might consider only doing it for a specific subgroup based on risk factors. But in this case, we found that it was not so difficult for the patients to apply the gel. The gel is not very costly, and the 60 seconds in surgery, it's not perfect, but we can do it. So I think it's probably just easier to do it for everyone.
Right. What do you think is the next step? I mean, you've come from 30 to 20 to 10%. Like, what further intervention can you envision that would take us to 5%?
Yeah, that's an excellent point, and I'm wondering whether we could even get so far. But yeah, I think there are so many factors that go into the disinfection and even the regular disinfection with the skin. You can use a lot of different substances in different concentrations. So of course there is a lot of room to optimize the perfect application with the perfect concentration, maybe which kind of antibiotics you use as a prophylaxis. I think it's mostly in fine-tuning. And so far I can't envision a big game changer, but if you have any ideas, I'm happy to hear it.
Well, certainly that kind of work, the optimization work to find the right dose, to find the right protocol is really important for these kind of things. But that research is not exciting. It's not as much fun, and it's challenging work to do, and it's work that I totally agree with you probably needs to come next here.
Yeah, when Peter and I evaluate all the abstracts, we looked at yours and both of us selected it right off the page. I think it's very impactful, and truthfully it helps to influence the care that we deliver. It's interesting that you use it not just in arthroplasty but across the board. I think it makes it much more systematic and builds a system in place so that we can more prophylax against infection. So congratulations on your work.
Thank you very much.
Yeah, congrats on your paper, and thanks for coming on and talk to us about it. And we're excited to see where your residency takes you from here.
Thank you.
We're joined now with Dr. Samuel Antuna of Madrid, Spain, who's going to discuss his paper, Shoulder Arthroplasty, First Clinical Results of Robotic-Assisted Shoulder Replacement. Dr. Antuna, welcome to the podcast.
Thank you very much. Thank you for having me here today.
Oh, it's our pleasure. Tell us what inspired you to do this study.
Well, actually, it's not in terms of because this was a kind of invited symposium, and they wanted to know what was my initial experience with robotics in shoulder arthroplasty, because I must say that I have been involved in the development of the software of the Mako for shoulder arthroplasty that has just been released in the U.S. It's not yet released in Europe. And because my link to that project, they asked me in SECEC to show what do I think, basically, and what was the basic research that we had behind all this Mako. And I must say that the project started a few years ago, and obviously you know that Mako has been extremely successful in the hip and the knee worldwide. We initially, after we developed the software, we did a basic research, the whole group, and just trying to elucidate whether our hands were better than the PSI or the robotics. And we showed yesterday that our hands are much worse, that what we can achieve with robotics. And we clearly showed that the positioning of the base plate was much more accurate with the robotics than with our hands, and even much better than the PSI. And even more, the quality of the reaming was really good. So after that, I asked the guys in the U.S., Dr. Peter St. Pierre and Joaquin Sanchez-Otelo, just to share with me their initial clinical experience, and that's what I really showed yesterday. And for what I've heard from them and all the data that they are compelling, it seems that it really improves the accuracy of the placement of the glenoid. So far, it's only the glenoid that is available.
So tell me, I mean, I think that's the crux of the issue is robotics better than a PSI guide, which is probably for many people in the United States the best available comparator right now? What is the real advantage of robotics over PSI in your mind?
I think it's too early yet to be adamant about is this better. It seems from the very early experience that the accuracy of the placement of the base plate, it seems to be better, at least in our study and also in the study that the group from Zimmer did. PSI is very accurate. It has the problems that you have to wait for those guides, and sometimes placing the guide within the glenoid is not that easy, depending on the case. Yeah. Robotics is just the robot does it. In the case of the Mako, as you know, they developed many years ago the haptics, and it really works as if it was the robot, and you just guide your hand. Obviously, there are no guides, there are no specific cumbersome situations, because the robot uses just a very small burr that just can fit into the surgical field easily.
And one of the biggest barriers to entry, obviously, is cost, right? When you're talking something to the tune of $1 million, $1.5 million, how do we democratize access to robotics?
Yeah, I wish I could do that. This is economics is just a huge issue. I tell you, I come from a system, the Spanish system, which is very socialized in terms of, it covers everybody, and it's very expensive. And more and more hospitals are acquiring the technology to do this. How I envision this, I envision it in the way that maybe in the future, the cost of all these robotics, if they really expand, across obviously the first world so far, the prices may go down. But it's true, that's the only but big problem that we have with robotics. And it's like cars, like in 1923, in the United States, if you're going to buy a car, it was extremely expensive. Now you can buy a car for maybe $10,000 if it's a very small car. So who knows, I was saying yesterday that the first time the cruise control of a car was developed was 1951, and today you can have an autonomous car in San Francisco that takes you from the airport to your house. And it took 75 years. Yeah. So we are in the very early beginning of robotics in orthopedics.
One of the things that I think is interesting in the U.S. market is that some of the push towards robotics is driven by patient perception and patient demand. The patients say, I want the replacement done with the robot. And so then surgeons, if they offer that, there are more patients that will come to them. Is this also true in Europe? Like in Europe, are there patients that are clamoring for this, or is there not that same culture?
No, it's not the same culture. There are patients that especially in private practice, that have heard about robotics, and they do believe that the robotics is better, and they may demand it. But in the national health system, usually, the patients do not have that perception that they are on command, on charge of what they do or what they don't do. So no, it's different. But I believe that more and more, because in my institutions we have a Mako, and patients know that they are going to get their knee replacement done by a co-piloting with a robot. And some of them they do ask, they do not demand it because they don't have the ability in our system, but they do ask, how is going to be my knee? Is it going to be a normal knee, or is it going to be a special knee? That's what they usually say.
So, you've talked about how glenoid is obviously what we have. That's the bird in the hand in the United States. Which are you more excited about, glenoid-based robotics or humeral side, where you look at center of rotation, premorbid anatomy, etc.?
That is a fantastic question. And I always say, when I'm on the podium, that the industry has spent a huge amount of money in developing software to understand the glenoid deformity. But in reality, if you read literature and if you have some experience in revision shoulder arthroplasty, you realize that the big amount of cases that come to you, the problem comes from the humeral part, because the humerus is not very well placed. So if you ask me why they started with the glenoid, I believe that all started at the beginning of this century when Jill Walsh realized that some of the glenoids would have a problem with anatomic implants, and after that paper, all the development of research on the glenoid came. But I truly believe that once we have, a good robotic system or a good navigation system, any device that allow us to do a perfect cut in the humeral part, we will indeed reduce the number of revision cases, because that is the key. And I am very much eager to see robotics in the humeral side.
And Brian, when I know you're using pre-op planning and transfer technology, and that it's really efficient for you right now. What do you see as the challenge I see with robotics is that it's initially not probably going to be efficient. Where is the break point? I guess that's the question, is how many more minutes per case is worth it?
Yeah, when I listen to Joaquin, he talks about the additional add would be about 10 minutes of time. And obviously he's a very efficient surgeon,
right,
and that may look differently for each individual. But I think the initial registry points, I think that the improved precision, but probably to a more practical endpoint, it's going to be that delayed gratification and seeing less revision for mechanical failure, base plate loosening, and potentially the other value adds from the robotics. So where that comes, whether that's 3-5 years or maybe the more delayed time point, as we heard from Dr. Salomonsson, the revision rates for an anatomic are nearly twofold higher in the Scandinavian registry. Could this help edge away at that? I think that's the big question.
Especially on the humeral side. I think that's going to be a really important piece.
I agree. I fully agree. And I think that's going to be a game changer. I mean, once we have a good device to do a perfect, because, you need to be quite experienced just to do a humeral part perfect, especially for the stemless devices, So yeah, and regarding timing, I've been navigating shoulders for many years now, not with robotics, but navigation. And at the beginning, it was a little bit longer than, I would say, just 10, 15 minutes more. But after 25 cases, actually we were gaining time because we were not using guides. It was just, so I believe that, the time that you spend with, placing the rays and maybe compensated by the fact that you are not, changing the guide, you don't like where the pin goes, all those things that the robot is going to do.
Well, I think you laid out really nicely to say that we're at the beginning here and that there will be gains in efficiency, in cost, in accuracy, and it's interesting to see what the future will hold.
Yeah, let's see. Everybody who knows me, I am a kind of a conservative guy. I don't really want to change things that work, and I do the same operation in a specific pathology since I was a resident, and I haven't changed it. But I am very enthusiastic about robotics and navigation technology, because, I am absolutely sure it's going to improve the outcomes. It's true it's going to be costly. It's true there is a learning curve. But at the end, in 50 years, our sons or our children, they're going to be technology dependent.
Well, congratulations on your work. And I think it's great that you're clearly a pioneer and an enthusiast in this area. We appreciate you coming on the podcast to tell us about it, and look forward to what the future will hold for robotics.
Thank you. Thank you very much, guys. Thank you very much for having me here.
Thank you, Dr.